to attend this meeting. As pointed out, my name is Festus Kisamwa. I am the External Relations Advisor with Maristops Kenya. My work at Maristops entails engaging both the state and non-state actors on a wide range of policy initiatives, including policy, legislation, budgeting, county engagement, among others. I have been with Maristops since September 2017, and therefore I have been engaging stakeholders both at the national and at the county levels of government, private sector organizations on SRHR programming, including maternal and newborn programming, SRHR, and family planning. Maristops Kenya works very closely with the Ministry of Health, in particular the Division of Reproductive and Maternal Health, on the issues that are on the table. And therefore, our discussions today, is not new to us. We have been deliberating on these issues over and over and over again. And therefore, this is basically an opportunity for us to refresh our minds on the issues that are pertinent to this country on SRHR. Let me start by saying that Kenya has over-legislated not only on SRHR, but on other areas. I have been a consultant on governance and policy before I joined Maristops Kenya, and I have done a lot of work on governance and policy issues. And I can tell you with confidence that this country has over-legislated. Go to the education sector, water sector, agriculture sector. We have got tens of policies and laws. The biggest challenge is rather implementation of the policies and laws that we have legislated. That is where the challenge is. Last year, before I start, we've had discussions on the school health policy of 2018. This is a policy that was developed by the Ministry of Health and the Ministry of Education, and it was meant to, among other things, enable discussions on age-appropriate comprehensive sexual education in schools. How many of you have read that policy? The school health policy of 2018. How many of you? You've read that policy?
Yeah, so, I reviewed it personally. Yeah.
Yes, so the interesting thing is that when we had discussions with colleagues from the Ministry of Education, interestingly, the ministry disowned the policy, a policy that had been approved by Cabinet Secretary and the Principal Secretary of the ministry. On the other hand, when you talk to the Ministry of Health, the officials acknowledged the policy and noted that it should be implemented. So you can see the contradiction when it comes to our policies, and in particular, implementation of the policies. So this is one line ministry that is telling us that school health policy should be implemented. And this is another line ministry that is telling us that this policy should not be implemented because it has grave mistakes. So the question is, why was this policy approved by 2 cabinet secretaries and 2 principal secretaries in the first place, if indeed it was not adequately developed. So there's a number of things that we'll look at, including the drivers of policy, the drivers of policy-making process. What influences policy-making process? What are the determinants of policy-making process? Why do policies exist in the first place? And in looking at that, I will make a presentation on the policy and the legal framework on SRHR with a bias on abortion and post-abortion care and related issues. As you may be aware, Kenya has been developing a number of policies. We've been supporting the Ministry of Health to develop a number of policies on SRHR and also on MNH-related work, including the post-abortion care. We've developed about 8 key documents on post-abortion care in this country. I personally have been working very closely with the Division of Reproductive and Maternal Health on the policy development process on post-abortion care. We've also been working closely with the SRHR program of the Ministry of Health on the reproductive health policy, on the review of SRH policy, among others. And therefore, I would like this discussion to be as interactive as possible. As you may be aware, the ministry has organized a series of meetings on the review of SRHR policy. There's a task force that has been set by the ministry, and discussions will start next week, but one in South Coast, and thereafter we will have discussions that will include partner organizations like ourselves. So the question is, are we going to get involved in this discussion? The answer is yes, we should. So we need to begin deliberations on how we get our voices heard in the review process. So I'm going to share with you what I have. It's a long presentation, but I'm going to summarize it so that we see what the policy and the legal framework says on the subject matter. Any questions before I start? Are we on the same page?
Yeah, from my end, yes. Hezron, maybe you could give Fester's co-host right so that he can share his screen.
Yes. I'm waiting to be given the right to share my screen.
Shortly, Festus, it's sorted.
Okay. Can you all see my screen?
Yes. Yes. Yes.
Okay. Okay. I am going to basically begin by looking at a number of policies and legal framework on the subject matter. But before I start, has any one of you involved in policy development process, be it with the Ministry of Health or health sector or any other ministry or department in this country? That's a question to all of us. How many of you have been involved in policy making process or discussions, not only in the health sector, but also in other sectors like education, water, agriculture, name them? How many of you?
There's one person in the chat box, Rogers Omolo, who has responded, yes. I think he means he has been involved in the policy making process.
Perhaps Rajas, can you tell us what has been your participation and your experience in policy development in the sector that you worked in?
Sorry, I'm traveling. I'm in a noisy place. I don't know whether you'll be able to get me.
I can get you clearly. My question, my question is, I would like you to share with us your experience and your take on the policy development process in whatever subject or rather area that you worked in, be it water, sanitation, health, agriculture, name it. What was your experience and take?
Mine, I participated in one in Homa Bay County, adolescent SRHR policy framework. The experience was good, but now the one that we were developing was stalled because of issues to do with budgeting and the lack of commitment, especially from the policy makers and from even the CSOs, because I noticed like most of the budget are left for the CSOs to support, so it was quite challenging. But it was a good experience because we started during formulation, from the idea point, formulation, and now I can say we are at the draft point. Like it's something that stalled, but now we are trying to revive it. But there's a challenge in terms of budgetary and lack of commitment from, especially from the policymakers themselves. Yeah.
So when you say lack of commitment and budgetary support from the policymakers, what exactly do you mean? Can you unpack that? And who are the policymakers that you engaged with in Homa Bay?
Like this one, we were engaging with the Department of Health. There's a representative from MOH, from County Assembly, and also those are the policymakers that we are working with. And then generally we are working with the local CSOs who are focusing on sexual reproductive health. And when I say lack of commitment, like they are not turning up for the meeting. Even if you organize meeting and you call them, the turn up is not there, or they just appear maybe for 5-10 minutes, which I don't feel it's enough for like engagement, and it's enough for like achieving what we want to achieve, because we want to involve them even in discussion. But now appearing and getting out after 10 minutes shows a lack of commitment. And for like budgetary, like I remember the one that we were doing, the budget was like 6 million, and for 6 million, the supporters, like we're working with LVCT, our organization itself. We were working with Kellen. We are working with EGPAF before, and we also work with other local CSOs. So, but this one was to be supported by LVCT especially, and because of the budget, they say the budget is too much and they cannot support that, just developing a document using 6 million. So it's stalled. Yeah.
So thank you so much. So how are you planning to handle that challenge so as to move forward and conclude on the policy, or you've just stopped it altogether?
Last week we had a meeting with the CSOs because we are also planning for other events, and we got opportunity to gather all the CSOs who are around, who are working, and I can say like we discussed it because like we wanted to track where we left, and now there's people who are coming in and are trying to like engage the CSOs and start working on it again. But now for the major challenge is because like we are trying to get the commitment from the policy makers. But now for budget, because we want to do it in a lower budget, we want to have it done in maybe, because like the proposal, like them people are proposing, like if we want to engage the policy makers, we want to take them out. Like if you take them maybe to Nakuru for that event, they won't be able to like keep coming out and going in. So those are things that we are still discussing, and we are still also reaching out for supporters who are able to support in developing the policy. Yeah.
Thank you so much for that. Brief, much appreciated. So we are going to look at the policy and legal framework, and basically, as you can see from the definitions, we will give a general overview and summary of the subject, including what is permitted by the law, including what the policy says, and what the policy framework looks like, on the subject matter. As you can see from the screen, we have only 5 countries in the world where abortion is totally banned. And in as far as the rationale for having the laws and policies on SRHR, maternal and newborn, abortion, name it, is concerned, the rationale is shown on the screen. Abortion, or rather unsafe abortion, has almost doubled in this country, and you can see the statistics. And therefore, with the 2010 Constitution, we set 4 parameters upon which abortion should be provided. We are going to see what the Constitution says and what other laws, including the Health Act of 2017, says. So you all remember the 2010 Constitution promulgation of the Constitution back in 2010, and therefore the Constitution opened up a new chapter on SRHR programming, and not only on SRHR, but on other areas that are of concern in as far as the promotion and programming of health is concerned. As I said before, Article 26(4) of the Constitution lays out the parameters for provision of abortion in this country. How many of you have held discussions on Article 26(4) previously, and what it says? Mudhoni Kamau, have you heard the deliberations on Article 26(4) previously? Mudhoni Kamau. David Odhiambo.
Yes.
I'm asking colleagues on our understanding of Article 26.4. I would like this training to be as participatory as possible.
Okay.
Have we had deliberations or discussions on what Article 26.4 says and what it does not say in as far as abortion and post-abortion care and emergency treatment and all that is concerned? It's either yes or no. Have you?
No, we've not discussed that in our trainings.
Not in this training, but in the previous engagements with CSOs.
Not yet.
Not yet.
Not yet.
Okay. So Article 26.4 basically lays the parameters for provision of abortion, and it says that every person has got the right to life. Life of a person begins at conception. The person shall not be deprived of life intentionally, except to the extent authorized by this constitution or any other written law. Now, I would like us to look at 4, which says that abortion is not permitted unless in the opinion of a trained health professional. I want you to underline the word a trained health professional, because we are going to look at what constitutes a trained health professional and who is a trained health professional under the Health Act of 2017. Okay, there is need for emergency treatment. So these are the parameters for provision of abortion in this country. 1, there is need for emergency treatment. So that is the first parameter. The second parameter is either the life, and the third parameter is the health of the mother is in danger. So up to the word danger, we have 3 parameters. Emergency treatment is the first parameter. The life is the second parameter. The health, the life of the mother, and the health of the mother is that's the third parameter. And the fourth one is any other written law. So those are the 4 parameters upon which abortion should be provided in this country. Is that clear on what Article 26.4 says? Any question? The challenge with Article 26.4, I'm going to be very honest with you, is that it is very subjective in the sense that it gives room for the trained health professional to make judgment. In other words, you may find a doctor judging a particular case and concluding that that case does not merit abortion. You go to another doctor and you present the same case with the same evidence, and that doctor or clinical officer or nurse merits, qualifies the case for abortion. So Article 26.4 is very subjective in the sense that it gives the trained health professional the room to judge whether case X or case Y or case Z qualifies for abortion or it does not qualify for abortion under the 4 parameters that I have outlined. And I'm going to repeat their parameters again. The first parameter is in case of emergency treatment. The second parameter is whether the life of the mother is in danger. The third parameter is whether the health of the mother is in danger. And the final parameter is any other written law. So those are the 4 parameters that permit provision of abortion in this country in line with the Constitution. Okay. So when you say a trained health professional, a trained health professional, when you talk about indications of, in case of an emergency, when the health of a woman is in danger, when the life of a woman is in danger in any other written law. So those are the parameters, the constitutional requirements rather, for provision of abortion in Kenya. Now, when you talk about any other written law, under Article 26, which other laws or rather law are we talking about? Based on our research, we have the Health Act, the Social Offences Act, and the Maputo Protocol. We are going to see what these talk about in relation to SAC or PAC programming. Health Act of 2017. How many of you have read Health Act of 2017? Mr. Odhiambo, David, have you?
Not yet, not yet.
Muthoni Kamau, have you?
Sorry?
Muthoni Kamau, have you read Health Act of 2017?
Not yet, not yet.
Rogers Omolo, have you read Health Act of 2017? Rogers, can you hear me? Rogers, can you hear me? Rogers cannot hear me. Is there anyone of you who has read Health Act of 2017? So I would encourage you to go and read this act and see what the act says on SRHR in particular, including MNH, family planning and author. So in summary, the act says that termination of pregnancy before the fetus is viable as an independent life outside of the womb. And it also defines emergency treatment as immediate healthcare administered to prevent death or worsen situation. So if we go back to Article 26.4, when we say in case of any emergency, let me just go back to Article 26.4 when it says that there is need for emergency treatment. There is need for emergency treatment. I want us to look at the definition of emergency treatment in the Health Act of 2017. So the Health Act says that emergency treatment is the immediate health care administered to prevent death or worsen situation. Okay. So the Act goes ahead and defines health as a complete physical and mental and social well-being, and not merely the absence of disease or infirmity. And this is a holistic definition in the sense that it doesn't limit to the physical well-being of an individual. Most of the times you find when someone is unwell and goes to a hospital, examination is basically, in most cases, it's physical. And therefore, there is need to look at the mental and the social well-being of an individual so as to ascertain whether someone qualifies for a procedure or doesn't qualify for a procedure. And healthcare professionals include any person who has been who has obtained health professional qualifications. And a healthcare provider is also someone who provides healthcare services, including health professionals. And a trained health professional, if you look at Article 6.2 of the Health Act, is a professional who refers to a doctor, nurse, clinical officer, or a midwife. So those are the four cadres who are required to provide abortion under Article 26 of the Constitution of Kenya. Okay. And procedures should be done in a facility with trained personnel and meets minimum medical standards, including infrastructure, commodities, supplies, and equipment. Any question on what Health Act says in relation to Article 26.4 before I continue? Are we now clear on what Health Act of 2017 says in relation to Article 26(4) of the Constitution of Kenya?
Sure.
Yes, yes.
Yes, yes.
And I would like us to be as interactive as possible so that we make the training lively as possible. Go ahead, Muthoni.
Yes, I'm clear. I've understood.
You have understood. Any question? Any question from any other person, or I continue?
Okay, from the chat box, there's no other question.
Yes.
Grace Edwards just also mentioned that she was part of the Kisumu County SRHR 2019-2024 policy draft.
Yes.
Yeah.
Yes. I would like us to look at these things clearly, because there has been a lot of misguided deliberations on SRHR programming in this country, despite the Constitution of Kenya, the Health Act of 2017, and other acts that we are going to see, despite them being very explicit on what is legal and what is illegal. And with this training, I'm certain at the end of it, we'll be in a position to engage strategically and also with objectivity and with evidence, so that when you go out there, we'll speak with evidence from the Constitution and from the acts of Parliament that have been enacted. The Health Act of 2017 says that every person has got the right to emergency medical treatment. It also talks about consensuous objection is a right, but make formal notification to those seeking it, and the consent is mandatory to the provision of services unless in a case of an emergency. So the issue of consent has been contentious. Let me say that consent, including parental consent, has been rather contentious in this country, in as far as what is the threshold for consent. So the Health Act says that it is mandatory in provision of services. However, unless it is in case of emergency. So if you are a doctor, if you are a clinical officer, if you are a nurse and you are presented with a case that needs emergency treatment, I want you to listen to what I'm saying. If you are a trained health professional under Health Act of 2017, a trained health professional is a doctor, a clinical officer, a nurse, and a midwife. So those four cadres, if any one of those four cadres is presented with a case that needs immediate emergency treatment under Article 26(4) of the Constitution of Kenya, and also under Article 9(1) of the Health Act. The Health Act says that consent is mandatory in the provision of services unless in the case of emergency treatment. I would like us to look at the Social Offences Act of 2006 and what it says. As you are aware, this is an act that has been in place for now close to 20 years or so. It was moved by the then nominated Member of Parliament, Honorable Njokindungu, and the ministry implemented the law by expanding the management of rape and medical management, include the prevention of pregnancy, management of pregnancy resulting from rape. So we are going to see all these things, and then we'll move next. So we have the national guidelines on management of sexual violence and rape, including the 2009 version, which is the second edition, and 2014 version, which says that termination of pregnancy as per the Constitution of Kenya, Article 26(4). So this is what we are calling the national guidelines on the management of sexual violence in Kenya. As you are all aware, sexual reproductive and health rights have really been, hampered by violence, including sexual and gender-based violence. Talk about rape. We've had very serious cases of sexual violence in this country, and therefore, what the ministry and other stakeholders have done is to come up with a number of guidelines, including the one that we are seeing on the screen. Now, if you look at this guideline, for example, it says that access termination of pregnancy and post-abortion care in the event of pregnancy from rape. So, in other words, as you can see from the title here, what are my rights as a survivor of sexual violence? I would like us to look at that subtitle, because when you're talking about SRHR programming, we need to look at what are your rights as a person, as a Kenyan. What are your rights? What are your rights? What is my right as a citizen of this country? What has the state done to institutionalize my rights, our rights, in as far as sexual violence is concerned? What has been done to address sexual violence in as far as these guidelines is concerned? So you have a right to choose when, where, and how, and with whom to have sex, engage in consensual sex, have your choice respected, willingness to decide to lay a charge of rape with police. And it goes ahead to, to talk about termination of pregnancy as a sort of rape and legal representation. So this information, colleagues, is important so that as we continue deliberating on SRHR programming, we know what has been done by the state, in as far as the guidelines development is concerned. What are the specific rights that are being given in each and every guideline or policy or act of parliament or the Constitution of Kenya, for that matter, and what has been done so as to disseminate this information. Okay, if you go to the rural area, to the countryside, do the folks there understand these rights? Do they understand that they've got the right on legal representation in as far as this particular guideline is concerned? Or people are simply afraid of reporting their cases to police for fear of either lack of legal representation or for fear of reprisal. So these are the things that we'll be looking forward as we continue. So we have the National Guidelines for the Management of Social Offences Act, which is that edition of 2014. And as you can see, a follow-up on pregnancy test at 4 weeks should be offered to all women who return, regardless of whether they took emergency contraceptive. EASY means emergency contraception after the sexual violence occurrence or not. It says that if a survivor intends to terminate a pregnancy which resulted from sexual violence, the healthcare provider and the survivor should be aware of the constitutional provisions in reference to abortion, and thus abortion is not permitted. In the opinion of a trained health professional, there's need for emergency treatment, health, or the life and the health of the mother in danger, or if permitted by any other written law. So basically, the third edition of these guidelines, affirms Article 26(4) of the Constitution of Kenya, in the sense that it says a follow-up pregnancy test at 4 weeks should be offered to all women. So if you are a healthcare provider and you are provided with a case that is a sort of abortion, it's a sort of rape rather, you should make reference to this guideline and also Article 26(4) so as to make sure that medical management of rape is addressed. So this is the National Guidelines for Management of Sexual Violence, third edition of 2014. And you can see other articles, it talks about emergency contraception that prevents unintended pregnancy. Emergency contraception should be available beyond working hours, and every survivor has got the right to access termination of pregnancy and post-abortion care in the event of rape. One thing that is common in all these guidelines, colleagues, is sexual violence as a result of rape. Now, this has been a big concern in this country. And therefore, as we continue deliberations on SRHR programming, I would like us to have a sort of paradigm shift from our comfort zones and face the facts. We need to face the facts, we need to ask ourselves, what are we doing so as to make sure that these guidelines are fully implemented, and that address the key concerns, on sexual reproductive health rights, issues to do with rape and all that. Any question on the guidelines before I go to Maputo Protocol? And do you find this training useful?
Yes, I have a question.
Yes.
When we check in the Constitution, you say the Act, what was it? Chapter 4, the bit of. Yes.
Are you saying the 8th Act of 2017?
Yes.
Or the Article 26(4) of the Constitution of Kenya?
What you said for the, what do you call this one? Just a minute. There's this, the national guidelines.
Yes, they have.
Yes, that one, the last, they have right to access something. Access termination of pregnancy and post-care in the event of pregnancy from rape. Are you not going to be prosecuted because you have gone against the Bill of Rights for, do you say Act 26, where they say you cannot terminate pregnancy after? Like, how do I handle that? Maybe I don't want to keep this pregnancy due to rape. And if I abort it, maybe I can be prosecuted.
Well, thank you so much for that question. And it is indeed a good question. So if I get it very well, you basically asking whether rape constitutes to emergency treatment.
Yeah.
Under 26(4).
Yes.
Now, someone has been raped.
Yes.
And there is strong evidence, documented evidence, including police abstract to that effect.
Yes.
So what does the law say is when someone has been raped, that person should have emergency treatment. Why is emergency treatment necessary? It's necessary so as to address issues to do with sexually transmitted diseases, HIV, AIDS, name them. It's necessary so as to address issues to do with the act itself. So a woman who has been raped got the right to access emergency treatment.
Okay.
If you look at Article 26 of the Constitution, emergency treatment is the first parameter upon which abortion should be procured. So if there is strong evidence to that effect, then as a healthcare provider, you should provide abortions. But the challenge is that you find cases that have been reported or even not reported to the police, and because of lack of a police abstract, because women rarely have police abstract after they have been raped, you find a healthcare provider, a healthcare professional not willing to provide the necessary emergency treatment for fear of reprisal. So these are the things that we need to carry advocacy on so that we can train our healthcare professionals on what these guidelines say, what the Constitution say, and what the Health Act say. It's all written in black and white, and anyone can go and make reference. And if it's not clear, you can seek further legal opinion, so that as you provide services, it is very clear to you on the parameters, on the do's and don'ts, and what the Constitution says, what the law says, what the national guidelines on the management of sexual violence in Kenya say. Have I answered your question?
Yes, you have answered.
So I would like us to look at what the Maputo Protocol says. So as you may be aware, this protocol of 2005, it was first of all signed in 2003, and with 49 states, and 3 did not sign, and it became effective in 2005. So the protocol is basically to the African Charter on Human Rights and People's Rights on Rights of Women in Africa. Again, how many of you have read the Maputo Protocol? Mudhoni, have you?
No, I'm hearing it for the first time today.
So this is a protocol that the Kenyan government ratified. And as you're aware, any international treaty and convention that the Kenyan government, the state has ratified, becomes part of the laws of Kenya. And therefore, Maputo Protocol, including other international treaties like the International Criminal Court, ICC, we ratified International Criminal Court. And therefore, ratification basically meant that it is part of the laws of Kenya. Maputo Protocol is indeed part of the laws of Kenya. And it outlines issues to do with SRHR, as we have been deliberating all along. So I'm going to narrow down to Article 14, and so as to look at what it says, and perhaps ask ourselves whether the government of Kenya has been implementing this article in line with its provision. So basically, it is the main legal instrument for the protection of rights of women and girls in Africa. So if you are doing SRHR programming in Kenya and African continent in general, you need to understand what the Maputo Protocol says. In Article 26.4 of the Maputo Protocol guarantees women rights to health, including sexual and reproductive health. Article 14.2c is the article that I want us to look at, and it basically says that state parties are called upon to take all appropriate measures to protect the reproductive rights of women by authorizing medical abortion. I want you to underline medical abortion. I want you to underline medical abortion in cases of sexual assault. I want you to underline sexual assault, rape, underline the word rape, incest, underline the word incest, and where the continued pregnancy endangers the mental and physical health of the mother. I want you to underline where the continued pregnancy endangers the mental and physical health of the mother, and or the life of the mother or the fetus. So when Kenya, ratified this protocol in 2010 with, we had all this in mind. Article 10.3 of the protocol, which relates to, all about militaries, blah, 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 blah. That is not, it's not, although it talks about reducing military expenditure significantly in favor of spending on social development and general, and in promotion of women in particular. Article 14.2c again refers to medical termination of pregnancy. This is specific to cases of sexual assault, rape, incest, and where continued pregnancy endangers the mental and physical health of the mother. or the fetus. It has been argued that the reservation in Article 26(4)(c) is inconsistent with the Constitution, given that it has got more specific and narrow limits the respect of termination of pregnancy. So we have the Maputo Protocol. Article 14(2)(c) basically gives a wide, parameters for provision of abortion, including medical abortion in particular, as a result of sexual assault, rape, and all that. So, and if you remember the High Court ruling of 2019 on the standards, on the sub-guidelines in particular, the High Court made a reference to Article 14(2)(c) in its ruling. So in other words, when the Ministry of Health withdrew the standards and the standard guidelines on abortion, the High Court made specific attention to 14(2)(c) and what it says in as far as abortion, rape, assault, incest, medical abortion is concerned. So these are the parameters that Maputo Protocol provides on the subject matter. Any questions on Maputo Protocol before I proceed? And I would like to ask the building or the time of whoever is controlling time to tell us the time that we have. Any questions on Maputo Protocol before we proceed?
Hi, hello, Mr. Festus. So there's one question in the chat box, although it's not directly related to the Maputo Protocol. Cynthia Wairimu is asking, what does the law say about a case that a man with 50 years has raped a 3-year-old girl, because it's really happening in her area? And then on the matter of time, we have 50 more minutes to go.
50 more minutes, okay.
Yes.
In time. So what does the law say about a case where a man with 50 years has raped a 3-year-old girl? Wow, this is interesting. So what is the difference between rape and defilement? What is the difference between rape and defilement? Maybe we need to define those two words. A girl who has been raped and a person who has been defiled.
For me, I think defilement is for any female who is below 18 years. Yeah, minor. And then for the rape is the one who is above 18.
Any other person?
I'm reviewing from a Google online resource, and they're saying that defilement, to make unclean or impure, such as to corrupt the impurity or perfection of, debase the countryside, to make physically unclean, especially, or to violate the chastity or virginity of deflower someone. So in that case, I think defilement would be focused on minors, but then in terms of rape, we're looking at a type of sexual assault usually involving sexual intercourse or other form of sexual penetration carried out against a person without that person's consent, with or without force. Yeah, so in my perspective, I would say when we're talking about defiling, these are minors. It won't be against their wish, but because you have charge over them, so they have no control whether you have sexual intercourse with them or not, you abuse them or not. But in terms of rape, we're looking at it from a person who, in a way, they could comprehend. I think so. We could give some more clarification on that.
And also, just on the same to defilement, you may find that it's not necessarily mean that you have to abuse them. Like it's perceived that any person below 18 years of age cannot have sexual consent. So due to undue influence that an older person will have on this particular young girl, for example, 17 years or a young boy, this girl willingly will be able to engage in sex. So it is, and as per the law, that is a defilement, whether she agreed or not, because this person is still immune to making a rational judgment as per the law. So it will not be necessarily have to abuse. You'll find that is willing, he or she is willing, but out of undue influence that this older person has.
Mm.
Yeah.
I like the deliberation. So I want you to look at this from this perspective. So these are two minors in secondary school, and they've engaged in sex. Okay, these are two minors who are aged between 9 and 11 years. They've engaged in sex, and as a result of that, the girl conceives. So how do you look at that case? As we've been seeing all this, the case of teenage pregnancy in this country, I have had the opportunity to work in all the 47 counties, and I've engaged, authorities, Ministry of Health officials on teenage pregnancy, And how do you look at that particular case whereby, adolescents and minors engage in sex and protected sex, and a girl conceives and drops out of school? So how do you look at that under the Social Offences Act? I open the discussion.
Excuse me, how do you look at it in terms of what? How the law would take its course, or just by understanding what defilement is
Yes,
amongst the two minors?
Looking at the definition of defilement and, vis-a-vis the Kenyan context. You see, laws are basically meant, to address these issues. Laws are, we are not supposed to have laws so that we become prisoners of law. We're supposed to have these laws and policies so that they can address our needs, our challenges. We have got a crisis on teenage pregnancy in this country, despite having all these laws and policies. So you as a school health administrator, as someone working in administration or Ministry of Health or an NGO sector, we have all experienced cases of teenage pregnancy in this country. So looking at the guidelines that we have as a country, how do we see these guidelines address the challenges that we have? We all have children, we have young brothers and sisters, some of them may have engaged in a protected sex. How do we look at these guidelines in reference to the challenge that is at hand? Are these guidelines helping us address the crisis of teenage pregnancy, for instance? That's the question. I throw the ball to you. Then you want to go ahead first.
Sorry.
Enough
words. On this is very interesting.
Go ahead.
This is an interesting case. We also consider that these are mature minors, because if both of them have started engaging in sex, we refer to mature minors. But in the context of this, I can say there's still a gap in the policies that we have, because we'll never be able to maybe categorize it as rape or defilement. But now when the law comes in, we'll see like the boys are the people who are being seen at the wrong and are being accused. But there's a gap. I can recognize that there's a gap in this, and it doesn't address issues for the mature minors and for the under 18. Yeah.
So when you that's in this. So when you talk about SRHR programming, that is a gap. What you said is a gap because despite enormous investment in legislation and policy development process, Kenya is unable to address the challenge of teenage pregnancy that is now out of control. Okay, we are unable to connect the policy or the policies and the laws to the practice, to the problem on the ground. I would like us to look at the, at your own time, you can look at Article 26, Article 8 of the Social Offences Act. And what it says, if you look at Article 8, sub-Article 1, it says that a person who commits an act which causes penetration with a child is guilty of an offense termed as defilement. And from sub-Article 2 to sub-Article 5, the Act gives penalties as follows. A person who commits an offense of defilement with a child aged 11 years or less. I want you to underline the words 11 years or less shall, upon conviction, be sentenced to life imprisonment. So if you engage in defilement with someone, with a child who is 11 years of age or less, you are guilty and the sentence is life imprisonment. At sub-Article 3, a person who commits an offense of defilement with a child between the age of 12 and 15 years. I want you to underline 12 and 15 years is liable upon conviction to imprisonment of a term not less than 20 years. Okay, sub-Article 4. A person who commits an offense of defilement with a child between the age of 16 and 18 years is upon conviction to imprisonment of a term not less than 15 years. See, the penalty, the penalty, is reducing. The threshold rather, is reducing as the age increases. Are we together? At sub-Article 5, if it is a defense to a charge under this section, if it is proven that such child deceived the accused person into believing that he or she was over age of 18 years at the time of the alleged commission of the offense. Okay, and if you read the below sub-articles, you'll see what it says. So basically, in responding to your question on defilement, I'm sure now it is clear on what should happen if defilement is proven beyond reasonable doubt. Can we move to the next discussion, unless there's a question on Maputo Protocol?
1 minute. So is it correct to say that institution only, the Sexual Offences Act only is geared towards just punishing the adults who defile young people, but there is no clear guideline that would that is set to just help kids that are having sex amongst themselves? Is it correct to say that we tend to assume that these children are not engaging in sexual activity?
I have engaged in that discussion, for many years. I can be very honest with you. I have had discussions with penal code institutions, prisons, prosecution department, investigation department, and you get the sense of the frustrations on how to handle these cases sometimes. I have visited, remand prisons, had discussions with probation departments, the children's department, And you get the sense of their frustration sometimes when, say, a 14-year-old boy engages in unprotected sex with a 13-year-old girl, and it later turns out that defilement, or there was no consent, so to speak, there was no consent, and the case goes to court. You get frustrations. It's hard sometimes to look at these cases with objectivity that is needed. And the question is, are these laws and policies, including the Sexual Offences Act, the Children's Act, do they really understand the complexity? Do they address the complexity of the issues? And if they do address the complexity of the issues, then why do we have teenage pregnancy? Have we done enough advocacy and information dissemination across communities, across our society on this law, so that people are aware of what the law says and what the law does not say, and so that people can engage, including our adolescents and youth, so that they can engage in informed decisions. And in answering that, age-appropriate comprehensive sexual education is indeed necessary. We may not have a one-size-fits-for-all. There's no a single policy that has got all the solution to all the problems. We need a holistic approach to the problems that face this country. Any other question or concern? Any other question or concern before I move on to the penal code?
There's no question in the chat.
Okay.
So I think we can.
Yes, I would like us to look at the penal code and what it says on SRHR programming and the issues that we have been discussing. As you can see, chapter 158 talks about procurement of abortion, chapter 159, chapter 160, all the way up to chapter 204 that talks about terminating pregnancy with skill and in good faith to save the woman's life. So we are going to see each of these and look at whether there are any contradictions in the penal code, and whether the penal code that addresses SRHR is in line with Article 26 of the Constitution of Kenya, which is the supreme law of land. For your information, the Constitution of Kenya is supreme. It is the supreme law of land, and it supersedes any other act or policy or guideline that has been developed. And in case of any inconsistency or contradiction between a particular policy or penal code or guideline, then the Constitution takes precedence. 158, of the penal code says that any person with intent to procure miscarriage of a woman, whether she is or is not with a child, unlawfully administers to her or causes her to take any poison or other noxious thing, uses any force of any kind, and uses any other means, whatever, is guilty of a felony and is liable to imprisonment for 14 years. Okay, I want you to think of section 158 and look at 159 says, any woman who, being with child, with intent to procure her own miscarriage, unlawfully administers to herself any poison or any other noxious thing, or uses any force of any kind, or uses any other means, whatever, or permits any such thing or means to be administered or used to her, is guilty of a felony and is subject to imprisonment of 7 years. So 158, the imprisonment is 14 years, and 159, and the penalty is 7 years, and 160. Let's see what it says. Any person who unlawfully supplies to or procures for any person or anything whatever, knowing that it is intended to be unlawfully used to procure the miscarriage of a woman, whether she is or not with a child, is guilty of felony and is liable for imprisonment up to 3 years. Now it's 3 years. So 158 is 14 years, 159 is 7 years, 160, section 150 is 3 years. Let's see what 240 says. A person is not criminally responsible for performing in good faith and with reasonable care and skill a surgical operation upon any person for his benefit or upon any unborn child for the preservation of mother's life, if the performance of the operation is reasonable, having regard to the patient's state at the time and to all the circumstances of that case. So I want to ask you a question. Reading section 240 of the Penal Code, 160, 159, and 158, what do you make of those 4 sections? Mugoni, let me start with you because I'm seeing you on the screen. What do you make of those Penal Code sections that are always quoted in a criminal court?
Yes.
I
was actually trying to digest them, the Penal Code. And for 158, attempt to procure an abortion, it's whereby a person she is doing intentionally. That is intentionally. And then 160, that one was a bit fast. I didn't get it well.
160 is on the screen. Check. 160 is on the screen. 160 on the screen.
I think this one is for the person who is conducting and knowing it's against the law.
Mm-hmm.
And then for the 240 is whereby the person 240. 240 is whereby the person is performing the procedures on a reasonable with the maybe issue that is related to it endangers the life of the mother or of the baby. So I think 240, the person performing it will not be prosecuted or something. Yes. And I really wanted for this penal code, is it found in the Constitution, or is it a different
the penal code? The penal code is enacted by the Parliament.
Oh, okay.
Laws are enacted by the Parliament. The Constitution is made by the people of Kenya.
Oh, okay.
Yes. So Muthoni, again, let me ask you, you assume that you are a clinical officer or a doctor, and you are presented with a case, and you decide to perform a procedure under section 240 of the Penal Code. You've looked at that case and you know that you'll not be held criminally responsible for performing in good faith and with care and skill a surgical operation.
Yes.
And then the police come to investigate you, and they decide to charge you with Article 158, attempt to procure abortion, knowing that punishment is 14 years imprisonment. So you have procured a procedure,
yes,
good faith and with reasonable care, as outlined in section 240 of the Penal Code. And the Kenya police decide to charge you under 158. Because, you as Muthoni Kamau, we intend to procure a miscarriage of a woman, whether she had a child or not, unlawfully, you unlawfully administered to her and taken poison, and to that effect, you are liable to prison for 14 years. What is your take?
So for 240,
the 240 is on the screen.
yeah, that means I have the skills and I'm performing it for the benefit of the client, not.
Yes.
Oh, I think that one it is unlawful because, as we have said in the Constitution, it has to be under the maybe.
No, I'm not talking about the Constitution here, Mudhoni. What I'm saying is under the Penal Code of Section Penal Code, Section 240, you will not be held criminally responsible.
Okay.
Mudhoni Kama will not be held criminally responsible for performing a procedure which is reasonable and there is due care and diligence. Yes. And is the preservation of a mother's life.
Yes.
Okay. You've done your duty in line with the Penal Code. Yes. How the police come and start harassing you. They start saying that you've gone against Section 158 of the Penal Code. And now they want to charge you, and we know the effect of that in case you're found guilty is 14 years.
I think I'll give them the code on for the 240, telling them this is what it guided me in performing that particular procedure.
Yes.
Yeah.
Yes. So what should you do? What should you do before carrying out a procedure under Section 240? What I think as a trained healthcare professional,
I think to have
so that the police will not come and start harassing you, start demanding bribes so that you're not charged under Section 158. That's what the police do. They come and say, we are going to charge you under Section 158, and you know what, the imprisonment is 14 years. So give us 200,000 or bribe us so that we don't charge you under Section 150. Knowing very well that the same Penal Code, Section 240, it says that you not be held criminally responsible, and you are adopted.
Yeah. I think you should. I should have all the documents, if it is a medical document that allows me to perform this operation without being criminalized. Yes. All the documents that are required for me to perform this particular operation or something, so that at least I'll have supporting documents so that I cannot be prosecuted.
Very good. So there are two things. There are two things that we draw from the Penal Code. The first one is the inconsistency of the Penal Code sections that we have looked at. This, we need to be aware of what 240 says, what Section 160 says, what 159 says, and what 158 says. If you are a service provider, you need to be aware of those four sections of the Penal Code. Secondly, so as to avoid scenarios where the police will come and charge you with the wrong Penal Code, having done your work diligently and professionally, you need to document it. As you said it rightly, Mudhoni, you need to have all the supporting documents. You need to document each and every case, each and every procedure, each and every case. You need to document and justify why this particular procedure was useful, or why was it necessary? Was it necessary in the preservation of the mother's life? So you need to document that and say that procedure X, this case was brought to my attention and I provided a surgical procedure so as to preserve the mother's life. And therefore, in performance of this operation, which was reasonable and having the regard of the patient said at the time, that procedure was necessary, and you support, as a medic, you give evidence, you give that evidence as to why that procedure was required if you document and you have all the supporting health-related evidence, then the police will find it very hard to charge you under Section 158. But if you perform a procedure with good intention and with in good faith and with reasonable care and scale, if you don't document, the police will come and ask you, where is the evidence that this particular procedure warranted this, whether this particular client or person warranted this particular procedure. If you don't have supporting documents, even with good faith and author, you may find yourself in the dock. So I've always told colleagues to have supporting documents, to have evidence, so that in the event the state comes to investigate you, you will have evidence that is beyond doubt. Any questions on the penal code before we go to next thing?
I'm asking, can we get like a soft copy of something of this penal code where I can be referring them to?
Yes, you can get the penal code. You can Google and get the penal code online.
Okay, thank you.
Yes, it's online. You can go to Google and get.
Sorry to rush you a bit, but we have 20 more minutes to go. And
Yes.
I'm not sure if Mr. Paul will be joining us today.
I'll talk briefly about what Paul was to talk about. So the 20 minutes includes my time and Paul's, is it?
Yes.
Yes, I'm going to take.
The sessions are limited to 2 hours, and we've already had 1 hour 50 minutes.
Yes. So I'm going to finish, and then I'll talk briefly about Paul was talking about referral, is it?
Collaborations and networking.
Building collaboration and partnerships.
Yeah, collaboration and partnership. So I'm going to talk about our work on collaboration and partnership. Any questions on the penal code? Because I wanted to spend a lot more time on this, because this is where healthcare professionals fall the trap. You do something with very good intention, with reasonable care and scale, in good faith, and therefore because of failure to document, because of failure to have evidence, the Kenya police will come and charge you with Section 158, and then you will find yourself in the dock. Any other question? If there's no question, allow me to go to the next thing. So the policy framework on MNH and SRH is indicated there. So we have the standards and guidelines of prevention of unsafe abortion, the 2012 ones. These are the guidelines that have been withdrawn but reinstated by the High Court. We have the MOH regulatory authorities guidelines. We have the post-abortion care guidelines and authored. We have WHO safe abortion technical and policy guidance of 2012. So as I said, MARSOPS has been working with the Ministry of Health on post-abortion care guidelines. So we have developed a post-abortion care pocket guide. I can share with you all the soft copies of these documents after this. We've also developed a post-abortion care curriculum. We have developed post-abortion care participants manual and facilitation of a lot of facilitators manual. We have developed a post-abortion care register. We have developed post-abortion care toolkit. All these are basically policies that are meant to provide the standards and the parameters for provision of post-abortion care. And therefore, currently, as I said, we are working with the Ministry of Health to implement a national health system strengthening project on post-abortion care across the country. And we are basically using these policies, about 8 policies that we have developed in the last 3 or 4 years or so. So these policies basically provide the parameters for provision, including training of healthcare providers on post-abortion care, including equipping county referral hospitals with requisite commodities, talk about MVA kits, talk about drugs, talk about FP commodities, including budgetary allocation at the county level so as to ensure that post-abortion care and SRH at large is mainstreamed at the county level. We've also developed a post-abortion care costed implementation plan, which has now been approved by the Ministry of Health, and it provides a broad framework for provision of PAC services in the next 5 years. We've got all these post-abortion care handbook for service providers that have been developed. And the advantages of the PAC handbooks, I've already mentioned that because they provide the opportunity for training of healthcare providers. Then in the last 3 months or so, we've been training healthcare providers from across the counties on post-abortion care. We've been working with the Ministry of Health and IPAS and the Reproductive Maternal Health Consortium. And these are just some of the letters that we have on implementation of policy. I'll share with you this presentation so that you see the thinking of the Ministry of Health on policy development in as far as to do with implementation of policy and maternity delivery and all that. You'll also be able to see the MOH regulatory bodies and the code of conduct and the scope of practice for doctors, clinical officers, nurses, and other cadres. The Code of Professional Conduct and Discipline of 2012 is also here, and you will see what it says concerning the National Training Curriculum on Management of Untitled Pregnancy of 2013. All these are some of the policy documents that I've been talking about. So I'll share with you this for your reading. Any questions before I address the last item? Any question on the policy and legal framework before I address before I briefly talk on coalition building and all that? Mr. David Odhiambo, did you find this training useful?
Yes, it has been useful, and actually it has enabled me to focus on now going to read the different policy documents and see how we can apply them in our work. Because in reality, practice might not be driven by these policies if we don't know what they entail. So
yes,
that's a critical piece for me.
Yes, so Paul was meant to address coalition building on SRHR. Is that correct?
Yes, that's true. Coalition building and partnership. So let me just read it for you. Coalition and partnership building for effective implementation of adolescent sexual reproductive health interventions and advocacy work.
So Paul told me to make a presentation on that subject because he is out of town this morning, and therefore he will not be in a position to present as discussed earlier. So Marstops Kenya has been working with coalitions on the subject matter. We've been working with the Caucus on Comprehensive Sexual Education, which includes 17 CSOs, hosted by Center for the Study of Adolescence and coordinated by SRHR Alliance. I know you know Mukali Kivuvani and Albert Obuyi. Do you know them? We also work under the auspices of the Reproductive and Maternal Health Consortium Kenya, which brings together about 20 national and international organizations working on SRHR, including IPAS, Marstops Kenya, Reproductive Health Services, Reproductive Health Network, among others. Marstops Kenya also works with national technical working groups on family planning. And this is a family planning that is led by the Ministry of Health. We are usually invited by the Ministry of Health on a regular basis so as to participate in discussions on areas that affect SRHR and family planning. We are also part of county-based technical working groups on FP and SRHR. And therefore, we have been participating in county advocacy, including budgeting for family planning commodities, and in particular advocating for setting aside of budgetary allocations for family planning. So in as far as our work is concerned, under the bodies that I have outlined, we have been working on a wide range of policy initiatives, including the reproductive health policy of 2020 to 2030. This is a policy that we began discussions sometime last year. I think it was mid last year. And as an organization, we provided a lot of technical and financial support to the Ministry of Health. We've also previously held discussions on and dissemination on the SRH policy of 2015. The policy came to an end last year, and therefore the ministry is now embarking on the review of that policy. And from what I have gathered from SRHR and gender program at the Ministry of Health, there is a task force rather that has been set, and the first sitting will be in 2 weeks' time. And the task force is basically meant to give guidance on the review of the policy. And therefore, after the task force meeting, we will have partners meeting so as to look at the SRH policy with a view to reviewing it and coming up with a revised policy. We've also done a lot of advocacy work previously, especially within the Reproductive Maternal Health Consortium Kenya. I personally engaged the consortium and the Senate on the review of the SRH bill of 2019, the Sexual and Reproductive Health Care Bill of 2019. And in our engagement within the consortium, we provided a memoranda to the National Assembly, to the Senate, with our recommendations on the bill and what it should say, especially for the benefit of women and girls of this country. Unfortunately, the High Court ruling withdrew 11 bills, including the Sexual Reproductive Health Care Bill of 2019, because it was said that it was approved by the Senate, but it emanated from the Senate, but not from the National Assembly. We, as a consortium, have engaged the government, in particular the National Assembly, on a wide range of issues, especially on advocacy. We have engaged the National Assembly, especially our contact persons, on budgeting, so as to ensure that family planning receives adequate budget allocations at the county level, and also considering that health is now devolved. There's need for us to engage with the Council of Governors and the county assemblies, as we have always done, so as to ensure that family planning gets adequate financing. For a very long time, financing for family planning has been the domain of development partners. However, when Kenya transitioned from a poor country to low middle income status about 4 years ago, donors began withdrawing their support for family planning. And therefore, commodities and training of healthcare providers now is slowly becoming the responsibility of the government of Kenya. And I would like us to look at this critically as we continue reviewing SRH policy of 2015 and any other policy that will come. The primary question is financing. You can develop a very good policy. You can have 100 coalitions. You can hold 100 workshops. Okay? But if you don't have financing, for family planning commodities, you don't have financing for healthcare providers, you don't provide training and on-job training for that matter for healthcare providers, if you don't provide adequate environment for family planning for SRH, then we will not be in a position to contribute to the indicators that we have set. Is that clear? Let me repeat it again. We can have all the discussions as we have always done as CSOs, but if we don't push the state to allocate funds for family planning and funds that are sustainable, financing of family planning that is sustainable in the long term, we will not be in a position to contribute to the key performance indicators on family planning and SRH at large. And if we don't, then we will have failed as a country. So the question is, will the government of Kenya set aside funds for SRH and FP? Will the county governments prioritize procuring family planning commodities using county government funds, not using donor money, not using money from the Gates Foundation or from World Bank or from DFID or from USAID, from taxpayers' money? Will the 47 counties prioritize family planning as other programs have been prioritized at the county level? We need to push for this. Otherwise, if we don't, despite all the enormous efforts and, in terms of advocacy, workshops, coalition building and all that, we will have fed the women and girls and also the men of this country and will not achieve the key performance indicators and will not sustain the gains that we have already made. So the challenge is upon ourselves and the Ministry of Health and the government of Kenya to ask ourselves, how are we going to ensure sustainable financing for family planning and SRHR at large is maintained without donor funding? That is the bottom line. That is the main question. As we continue revising SRH policy on any other policy that will come along, the first question is financing, and financing that is sustainable. Financing that is sustainable in the long term, so as to ensure that the dividends that we have had so far on family planning are sustained in the near future. I can tell you for a fact, donors will continue reducing their financing for family planning in this country. And therefore, as the donor funding decreases, financial allocation from the National Treasury should increase, and therefore county government should also increase financing for family planning. If you look at what the counties have done, for the last 3 or 4 years or so, you find that out of the total health budget takes about 24% to about that 32% of the national county budget. So out of that bracket, family planning budget is less than 1%. Sometimes it's 0.3%. So you can see counties really allocate very little, sometimes nothing at all to family planning. If a county has set aside 28% of the county budget to health, and family planning gets less than 1%, then we are in a crisis. We're in a crisis in terms of domestic financing. So as we continue our advocacy, our advocacy for finance, for sustainable finance for family planning, we need to use evidence. We need to use data. Do we have the data to inform our advocacy? The answer is yes. So we need to make use of the data we have every nil allocation for family planning at the county level. Kakamega County has at least done very well compared to other counties, even though it is not what I would call as a good example. But it has been argued that the county has allocated about 3% of the total health budget to family planning. There are other counties that are stagnating at 0.1%. So we need to use this evidence. We need to use data in our coalition building. We need to work in coalitions. We need to strengthen our coalitions. We need to be part of the coalitions that drive social change. Coalition, the caucus on CSC, the Reproductive Maternal Health Consortium, the technical working groups on family planning at the county level also, health network NGOs. We are part of the Health Network NGOs. We usually receive briefs on a weekly basis. We are part of Global Financing Facilities CSO Coordination Forum, whereby we look at the RAMCA indicators and identify the gaps that are there progressively, and also provide our reports to the authorities, especially the GFF coordination mechanisms, so as to ensure that the gaps are addressed, including issues to do with misappropriation of funds where there's evidence, including lack of or inadequate adherence to the global financing facility mechanism, and issues with the reporting and issues with the data fraud. So we need to ensure for us to undertake informed advocacy, we need to have data, we need to have evidence, so that as we make our voices heard, we use evidence and strong evidence to that effect. So that's what I had under coalition and what called for us to present. Any questions?
Yes, Festus. Based on the presentation that you've made, there are different networks that Mary Stopes is involved in and engaged in terms of driving policy, looking at how to improve access to sexual reproductive health services and related. How can the youth-led organizations and initiatives within these kind of training that we have in this platform plug into these kind of avenues and platforms as well, so that they support the work they're doing and also contribute in terms of informing the policies? Would you share specifically on such kind of intervention?
Yes, so yes, to answer your question, I can take the lead so as to bring you on board in the Reproductive and Maternal Health Consortium. So what we have is that we usually give memorandum of understanding to organizations, including the youth one, willing to join the consortium. And in joining the consortium, you'll be connected to the best brains, and the best minds in this sector, with the best on the most experienced, professionals from University of Nairobi, from learning institutions to others. So I can take the lead so as to, among other things, share with you the draft memorandum of understanding and also connect you to the coordinator of the consortium, someone that is called Dr. John Nyamu.
Okay.
A friend of mine. I can also connect you to Mwekali Kivuvani and Mr. Albert Obui of SRHR Alliance and focus on comprehensive sexuality education.
Yes.
You can be part of that. I can also connect you to the Ministry of Health so that you can be part of so you can be invited in the next technical working group on family planning. and also the discussions on the review of the SRH policy of 2015. I can find out how your involvement can be helped. So I have noted that.
No, perfect. That's okay. So maybe
Yes.
once you share those details, I'll also engage the team and we find ways of supporting and plugging into those networks. I believe we can work collaboratively and drive this agenda together. Yeah.
Yes.
Perfect. Thank you. Any questions, any concerns from the participants?
And also in addition to that, I can also connect you to Reproductive Health Network, RHN. We usually have our annual RHN conferences. And in our RHN conference last year, it was resolved that this year's RHN conference and subsequent will be youth-led. Because the challenge is that we've been having these conferences that are not youth-led, and therefore we address matters to do with adolescent and youth, but you find that the representation from the youth coalition, the youth group is very small. So we resolved to include youth and have the conference led by the youth so that we can hear your voices about the matters that affect you.
That's fine.
Yes.
And when is the conference supposed to be taking place this year?
Which conference is this?
The RHN Kenya, Reproductive Health Network.
Well, I have not checked this year actually. The last conference was last year. I think it was in November last year.
November, December, yeah.
I've not reached out to Nelly Munyasia, so perhaps that's an assignment. I need to reach out to find out whether it will happen because of COVID-19 and all that. I need to find out the planning for RHN conference for this year. I have not checked with RHN, for the last 2 months or so.
Okay.
Do you have any connection with RHN conference?
Not really. There's a point that they wrote an abstract that was considered for presentation. So that is the last time I engaged with them.
Yes.
Yeah. So, but it's okay. We can follow up and see how we can engage and also see the opportunities that are coming. Because I know some of the people within this group, these are young people, youth-led organizations, so they can plug in and actually shape the conversation.
Yes.
Yeah.
Yes, and also drive the agenda so that the agenda is youth-led.
Sure. Okay. And just to give you an update, one of the things that we were hoping on at the end of this session, this is the 4th session, we have 2 more to come. After that, in December, we are planning to have a youth-led kind of virtual summit where we'll have the very participants we've had share some of the work they're doing in terms of policy interventions, what are the best approaches in driving their access to work care that they do, and how can they collaborate with people like the MSK, the SRHR Alliance of Kenya. How do we bring them on board to sustain the work these people are doing in the ground? Because they're with the communities. So that is a session that we'll be having, and hopefully I'll engage you after this. Then we see how we can plug in and bring these other stakeholders as well on board.
Absolutely, I hear you, and you make a very valid point. As an organization, we are open to your ideas, and we'll take your ideas as long as they are aimed at promoting SRHR space
Sure.
country.
Sure, perfect. Thank you so much.
You're most welcome.
Any other questions? Any other contributions from the participants? I can see we all actually 7 minutes. Modoni, you have something. I can see in your smile.
Yes. Actually, I think this session has been very insightful for me. I have a lot of screenshots and some of the things that I'm going to look at them immediately after this session. And I'm looking forward for those networking and participating fully in ensuring that the youths, I think most of the time we don't understand these rights and these bills. So if we have the exact information when you go to the ground, even if we'll be giving like one right or one act that the participant can understand and know clearly when they're seeking these services, I think that is a very good step for us to start. So thank you so much, Mr. Festus, and for the Ryculture for this amazing training. Thank you so much.
You're most welcome. And Modoni, I'm one person who is very open, and my line is always open. So you can always call me for information or for any support that you require from Maristops. We'll look at it and we'll provide feedback. I am one person who likes working with the youth because the future belongs to the youth, you know, and therefore you need to be in the forefront. Gone are the times when the youth used to take the back seat. You need to be in the front. You need to be in the front. You know, we are having a general election next year, Muthoni. You need to be in the ballot. Mr. Diambo, you need to be in the ballot. You need to be, your voices need to be heard. What is the voice of the youth in the next general election? We're not going to have the same people who have been in the election since 1980s and 1990s, being in the election next year. We need to see Muthoni Kamau in 2022. We need to see Roger Somoli in 2022. Mr. Odhiambo David, you need to ask yourself what would be your take in the next general election. SRHR issues with the SRHR in the next general election. Are we going to have our voices on SRHR heard in the next general election?
That's the question, yeah.
Food for thought.
Yeah, that's food for thought. Because at the end of the day, that is where the decisions are being made. So if we don't inform those decisions, they'll be made against us or in a way that does not align with what we aspire for. So that's a challenge for us. And I hope all of us have registered to be voters so far. So that is where it starts.
David, are we having like the feedback questionnaire that we normally fill at the end of the session?
Yes, it's ready. Michelle will share it. I don't know if Michelle, you're able to share it here now, or you'll send it with an email with the recording of the session.
Okay, thank you.
Yeah, so that will be sent to you. And just to follow up again, in terms of the policies, there's a program that we started last year. It was the health roundup discussion. So I don't know, Hezron, if you're here, you can maybe give a brief. You can see some of the recordings are on YouTube as well, the health roundup. So the main aspect was to discuss policy issues and their implications, whether you are a person working in that space. If you are not a person working in that space, then even an investor, the general public, because at the end of the day, we are all impacted with the healthcare needs that we have. So how does that come into play? So I don't know, Hezron, you're here? I think he's not in a position to speak, but if he gets back, that would be good. And you can also check it online, so that would be amazing. Yeah, so that is as far as it goes for me. Unless there's any question, any other thing, then this will be the end of our discussion. And thank you so much, Festus. It's been great working with you, engaging with you. And I remember meeting you the first time was on 23rd of June, 2019. That was during the Kenya Healthcare Federation members meeting. And it's been a great engagement so far. So
that was at Kempinski?
Kempinski, yes.
Yes, that was at Kempinski, I remember, and I addressed the people, and by then I had my colleagues, Dr. Laila, and Moses Mwaniki, and another friend of mine called Mr. Omondi, who was in charge of healthcare financing, Edward Owino Omondi. So we were
Edward, yes, you are four.
Yeah, so we are grateful. I always believe in growing up, and I can also learn from you, and I've actually learned from you, Mr. Diambo and Muthoni and Rogers. You people are so informed. You're so informed because you are now at the national, and very soon, if you're not at the global, you'll be at the global. So you've really done a lot within a very short period of time. What has taken me to build in the last 20 years or 20 plus years has taken Muthoni just 5 years to be at my level. So meaning that you've worked very hard than I worked when I was at your level. So it shows that you are actually working at a very high speed and with precision during my time, So keep up, and I look forward to engaging you. I look forward to having coffee with you, Mr. Diambo.
Sure.
And let's engage via email, via mobile phone, so that we can share information and build each other.
Perfect. I'll really reach out. Then we'll engage. And as much as we've been able to do this within a short time, you guys laid the foundation for us. Without that foundation, we wouldn't be able to do it as much as we've done. So that is a great contribution. So thank you so much. And I can see Michelle has shared the feedback form. Guys, get to it, share your feedback, the best lessons that you've captured today, some of the things that we can improve on, so that at the end of the day, when we have the next offering of this program, we are doing it in a better way, and you're making improvements where there's need for improvement, so that we continue doing this work together. Asanteni sana, and have
So
a
the feedback, Mr. Odhiambo, has been shared by Michelle. Is it in Word or it should be filled online?
It's a Google form.
It's a Google form. So
yes, so they click on the link, then they'll access it from there.
I'm trying to look at the link and I can't see the link has been sent now.
Yes, it's in the chat box. Yes.
It's in the chat box.
Yes.
Okay. So okay, fine. I thought it. So I've seen it. So I'm going to fill it now, and once I fill, it's just click share and it shares. It goes to.
That will be it. Then once we have that feedback, we can guide ourselves, and also we'll share the reports from all the sessions that we've captured with everyone.
Yes.
So that at least we all understand what we gained, what we didn't gain, how do we improve moving forward, and then we get your perspectives as well and build from there.
Yes.
Sure.
Very good.
Thank you, everyone. Have a great weekend ahead, and we'll keep in touch.
Thank you.
Thank you.
Bye.